Good morning, Dr. Chris Walker. How are you?
Good. How are you, Steve?
Good, Chris. Thanks again for taking the time to chat with us about the use of radiation therapy for melanoma. And before we get started, I want to just introduce you. So, Dr. Chris Walker is a radiation oncologist at the Memorial Sloan Kettering Cancer Center. Prior to joining Sloan Kettering Cancer Center, he was I believe the Howard Hughes Research Scholar at the National Cancer Institute, and he has been at Sloan Kettering since 2006. Has a really special interest in treating skin cancer with radiation. He's one of the few radiation oncologists in the country focused almost exclusively on skin cancer. Now, in addition to seeing patients, Dr. Barker is a director of the clinical investigation program at Sloan Kettering Cancer Center. He has led a number of trials, most of them sort of focused on the use of immunotherapy combined with radiation for treating different type of skin cancer. So, Chris, thanks again for taking the time and joining us on this Beating Melanoma project.
My pleasure. I'm happy to be here.
So, before we jump into various indication of radiation for treating various different type of melanoma, maybe we can step back. You can give us a background about how does radiation work? You used various modality like X-ray therapy, brachytherapy, proton therapy, and what are those modalities and how do they all sort of work in a very general sense?
Sure. So when it comes to cancer radiation therapy, generally what that refers to is the use of high energy ionizing radiation. And this is typically directed to a tumor or an area where we think cancer cells may be. And fundamentally, we think the biologic effect of this is that the high energy ionizing radiation can damage cells and ultimately lead to their death. Now, obviously, the cells that we're trying to damage and kill with radiation therapy are cancer cells. And we think that generally speaking, cancer cells are more susceptible to the deleterious effects of radiation than normal healthy cells are. However, during a course of radiation therapy, it's not unexpected for there to be some damage or injury to those nearby healthy cells. And that, generally speaking, is what leads to side effects. So side effects of radiation therapy can vary, depending what part of the body the radiation is being given to, how much radiation is given, the way in which it's applied. But this is essentially kind of the binding theme for cancer radiation therapy. And as you mentioned, there's different ways that we can deliver high energy ionizing radiation therapy for cancer. Broadly speaking, brachytherapy and teletherapy or external beam radiation therapy are kind of the two categories of radiation therapy that I, as a radiation oncologist, use and would be used in the treatment of melanoma potentially. Brachytherapy just refers to putting a radioactive source or device very close to where the tumor is. And letting the radiation, emit over a very short distance to where the cancer cells are. Again, teletherapy or external beam radiation therapy involves the use of a machine that produces a beam of radiation, and that beam is sent to the area where the cancer cells are. You can sort of think about that like the beam of light that comes out of a flashlight. This is often how I describe it to patients. You turn a flashlight on, a beam of light comes out, you can shine it where you want it to go. And in a similar way, we use a big machine that produces a beam of high energy ionizing radiation and send that beam where we think there could be some cancer cells. These are kind of the more common forms of radiation therapy for melanoma. There are other ways to deliver radiation. For example, in some rare situations, you want to give radiation to the entire body. You could do that with a beam of radiation. That has been done in the treatment of melanoma prior to autologous cellular therapy. It's not commonly done at this point, but it has in the past. There's also methods of delivering radiation to the entire body or body compartments using unsealed radioisotopes. Again, not something that's been done very often for melanoma, but for other cancers, for example, prostate cancer, this is a standard treatment. So, yeah, I mean, in short, there's a lot of ways that radiation therapy can be used for cancer, including melanoma.
Got it. I mean, I think that's a very good global overview on how everything works. And so next other question is, before again we jump into it, I remember, I think the first grand round you came to the Durham grand round, and prior to you joining us in 2006, we always have this kind of a misconception. We're thinking that melanoma is perhaps radio resistant. It doesn't work as well. I remember first few times when you start speaking to us and you showed us some of the literatures. Can you talk a little bit about that? Like, why is it that at one point people think radiotherapy doesn't work for melanoma, and like how does this get changed?
It's a very good question, and it really takes a long look back into the history of radiation therapy and the treatment of melanoma, which is something that goes back, 100 years basically. Some very early reports from centers, that took care of a lot of people with melanoma, including, Memorial Sloan Kettering, or what is now Memorial Sloan Kettering, suggested that the use of radiation therapy didn't, lead to a response very often. That was kind of the conclusion that people arrived at in some of those early retrospective clinical analyses. If you go back to some of those, including one very famous one from Memorial published by Dr. Frank Adair in the 1930s, and you look at the data, there weren't too many patients that were treated with radiation therapy exclusively. But if you really look carefully at the data, their outcomes actually are quite similar to those treated with surgery, which is considered, the standard of care, still at this point for many people with melanoma.
Especially back then, that you're taking a much, much wider margin,
Yes. So, I mean, the approach with surgery in those days, as well as with radiation therapy, is likely very different than what it is today. But, subsequent studies kind of looked into this trend, and, there was a suggestion that melanoma didn't respond as often to radiation therapy as other cancers. But really, if you kind of look very carefully, what you find is that there's a wide range in terms of the responses that you see. There are patients that do respond. There's no doubt about that. Good research studies have shown that. But it's not as though all patients, with melanoma respond to radiation therapy. Frankly, the same could be said of almost all other cancers as well. So melanoma is not unique in this respect.
So the bottom line is the stuff works.
It can for some patients.
Yeah,
I mean,
I think there is a certain specific indications, and I think one of them is, lentigo maligna, right, on the face. And just for clarification, lentigo maligna is a type of melanoma in situ, mostly localized on the face or sun damaged skin. Surgery usually the option, but sometimes the patient is too frail or the tumor is too large that we needed some other modality to treat. And why don't we talk about that first, and the efficacy of radiation for treating lentigo maligna?
Yeah, I mean, this is, another one of these topics that, some of the earliest reports that I've found on using, methods of radiation therapy, which we wouldn't use these days, but, were certainly standard at the time in the 1940s, 1950s. These early reports show quite clearly that, large facial lentigo malignas can respond to radiation therapy. By response, I mean, that pigmented area loses its pigment and appears to normalize. Over the years, this treatment has been used selectively. What I mean by that is that patients are primarily chosen for this on the basis of the extent of the lentigo maligna, how large it is, and whether, they're suitable candidates for other treatments. As you as a surgeon know, typically surgery is considered the best treatment for lentigo maligna. In my view, that's because, number one, it removes the, condition, the neoplasm. And number two, it tells us, it gives us information about what's actually there. other forms of treatment generally, including radiation therapy, don't tell us additional information about the lentigo malignant. But, as I was saying, patients that were selected for radiation therapy, they often weren't good candidates for
Sure.
surgery. The lentigo malignant was too large, too extensive to remove with surgery. Perhaps they were elderly, weren't medically fit enough to undergo a large surgical procedure. And so historically, reports on the use of radiation therapy for lentigo malignant involve, patients that just weren't good candidates for other treatments. And there's a wide range of experiences that have been published about this, the efficacy of this. Some of the larger series are from Europe and suggest that between 80 and 90% of the time, radiation can control lentigo maligna. But bear in mind that these were in patients that were selected specifically for this treatment. So that introduces some bias, and we have to kind of keep that in mind as we interpret those research studies.
So Chris, let's say, a patient of mine, and I deemed that she or he is not a candidate for surgery. I send that patient to you, right?
Mhm.
How would you consult that patient? What's the process? What would you tell them?
So, I would basically discuss what we know and what we don't know about using radiation for lentigo maligna. I would indicate exactly what I just mentioned. That is, this has been done before. Doctors have looked at the efficacy of this and shown that, 80 to 90% of the time, radiation seems to produce a response in a lentigo malignant, seems to control it. Some of the caveats are that, generally patients are selected for this treatment on the basis of being ineligible for surgery. And most often this happens because patients are elderly. As this happens in people that are older. And what tends to happen in older patients is that we don't follow them for as long. So the long-term success of radiation therapy for lentigo maligna is not something that's entirely clear.
Hmm.
And again, primarily this is because patients that are selected for this are elderly, and we just don't have long follow-ups with them.
So before we even get to the prognosis and follow-up, but like in terms of, can you walk us through the logistics, like how frequently and what modality you're using? And
Yeah.
so let's go through that first.
Yeah, so generally speaking, I would use an external beam radiation therapy approach for somebody with lentigo maligna. As you know, these tend to be very, very superficial neoplasms.
Sure.
And I emphasize the word neoplasm here because lentigo maligna, as you know, is not an invasive melanoma. It doesn't have metastatic potential. And so this is really a pre-malignant condition. I always emphasize that to the patients because often, people hear melanoma and it provokes a lot of anxiety.
Sure.
And really being clear that, lentigo maligna is not invasive melanoma. These are very different entities in terms of their behavior, their natural history. But again, because this is a superficial skin neoplasm, we can often use superficial forms of external beam radiation therapy. In fact, the Europeans have largely used something called Grenz ray therapy, which involves ionizing radiation that's kind of the lowest energy ionizing radiation that we have available. I haven't used that. It can be a little tricky to use that if you don't have the necessary calibration equipment. I've generally used what's called superficial radiation therapy, around 100 kV energy X-rays, and these penetrate very superficially, just a few millimeters under the surface of the skin, and that's sufficient. Generally, we give the radiation therapy in a series of little doses. The reason that we do this, or we fractionate the radiation, is to try and prevent side effects, both short-term and long-term. Now, this obviously is something to consider carefully in someone who is potentially limited in terms of their functional ability, their ability to come in for treatment, their life expectancy, the need for many, many, many weeks of radiation therapy may not be as great as it is for someone who's perhaps younger, has a longer life expectancy, and you really want to prevent those long-term side effects from happening.
And just on average, how
Mhm.
frequently do they have to come in, and how many those fractions are you talking about? 20 over a course of 6 weeks, or?
Yeah, so typically for lentigo maligna, the regimen that I've used is around 20 to 25 treatments over 4 to 5 weeks. However, shorter courses or fewer treatments can be considered, perhaps as few as 5 treatments over a span of 2 to 3 weeks can be used. And again, that decision is primarily based on one's life expectancy and a patient's ability to come in for these treatments and of course their perspective on long-term side effects.
So the bottom line is, let's say if you can fractionate this longer, meaning you give smaller dose and do a longer period of time, and you will have, theoretically less of side effects, right? And but if most of the time, but you have to meet the logistics because patients sometimes may not have the transportation or caregivers availability, sort of taking them every day to the centers. And
Yeah.
those treatments are relatively quick, isn't it? Like when the consultation process is a little bit long because you have to explain it on the first time. But once you set up this, and when they come in, it's how long usually take? 10 minutes or so per each visit?
Yeah, I mean the treatment visits do tend to be brief, anywhere from 30 minutes to an hour. Most of that time, is spent us getting the machinery all
Sure.
set up and ready for the patient, getting the patient, into the position they need to be in for treatment. We're double checking, we're triple checking. Once everything looks perfect, then the radiation machine turns on and the beam of radiation is delivered. And that delivery of the radiation is brief. I mean, 2 to 3 minutes usually, depending on the amount of radiation given. Patients don't feel anything during the radiation. You hear the machine make some noise, but it's not as though you can feel the radiation being delivered with each treatment. And generally speaking, they feel the same way when they leave the department from their treatment as they did when they walked in.
And the most important thing is when they lie there during the 2 to 4 minutes when the radiation is actually they're getting the exposure, they shouldn't be moving around. They should just sit still. That's perhaps the most important thing. I guess your staff will remind them.
Yeah, and there's ways that we can ensure that the radiation is being delivered accurately. In some situations, we'll actually create devices that help keep the patients still and in the same position for treatment. That's not always necessary. To some degree, it depends how the radiation is being given, where the radiation is being given, and the patient's abilities as well.
So, and what should they expect? I mean, at what point do they see the erythema, the sunburn-like reaction, and what percentage of patient will actually get this kind of a like desquamation and peeling, and also what kind of aftercare that you give to your patient?
Yeah, so usually around 2 or 3 weeks after radiation therapy starts, you begin to notice the inflammatory effects of the radiation in the skin. That usually manifests as the skin getting pink and then getting red. It could become itchy, it could become sore. It's like having a bad sunburn, basically. And I would say that most patients having radiation therapy for cancer of the skin can expect to experience this.
Sure.
Um, and the good news is it's like a sunburn in that it's temporary. A few weeks after the radiation therapy is finished, this inflammatory effect on the skin starts to resolve. Now, again, you asked what fraction of patients experience this. Almost all will experience, erythema or redness of the skin. The desquamation or peeling of the skin, not everyone experiences. To some degree, this depends how large an area is being treated, whether this area of skin has been previously exposed to the sun, has been sun damaged or not. There's some things that we can do to try and help, take care of the skin during treatment. Topical emollients, moisturizing creams, sometimes topical steroid medicines, things like cortisone. They can reduce some of the inflammation in the skin and make it recover a little faster. Sometimes if there is peeling of the skin, we'll recommend things to kind of help prevent infection, help the skin heal. But again, generally that process starts 2 or 3 weeks after the radiation's finished. And, we're seeing our patients after treatment to check in, make sure that healing process is going along as expected. And in most cases, it is. It's unusual to have like prolonged dermatitis or inflammation of the skin, more than a month or so after treatment finishes.
Especially if you sort of fractionate this like really, really like numerous fractions instead of delivering it really quickly, basically. So what kind of you just basically after the radiation, you're just basically telling people to put on some sort of moisturizer, lotions or creams and over the area and keep it moist. Is that the only instruction you give, pretty much?
Um, well, the moisturizers are helpful because the radiation can make the skin dry. Skin dryness in and of itself is usually not a terrible problem, and depending on the part of the body, for example, the nose it's pretty rare for the skin to get
Sure.
dry. It's quite oily. Um, but if the skin gets dry, what can happen is it can become itchy. And if it's itchy and we scratch it, that can lead to infection. And certainly having a skin infection in the area that you're having radiation therapy would not be a good idea. So we try and prevent itching from skin dryness by using a moisturizer. As I mentioned, the radiation therapy can produce inflammation of the skin, that redness, and that can cause itching as well. So for similar reasons, we'll use an anti-inflammatory medicine like a steroid ointment to help curb some of the itching. The steroid ointments are quite good at doing that, really to try and prevent scratching of the skin in the area where the radiation is. Um, and then, after that, in terms of the progression of the effects of the radiation on the skin, we're largely looking at, the barrier functions of the skin. If the skin starts to peel and lose its barrier functions, it could lead to infection in the skin. And so we're primarily focused on,
Barrier
using,
repair and
yeah, things that
got it.
can kind of, keep the barrier intact, prevent infection from happening, monitoring for infection, all those sorts of things. And again, with time, provided that the right amount of radiation has been given and not too much, the healing process usually kicks in around 2 or 3 weeks after the radiation is done, and patients are starting to feel better at that point.
That's good to know. That's a good time frame that for folks to know. All right, we're gonna shift gears a little bit. I know we touched, one spectrum that is like lentigo malignant melanoma in situ. They don't have invasive disease. Let's go on the other end, that metastatic melanomas, and distant mets. And how is the radiation being applied in that setting?
For patients with melanoma that have distant metastases, generally speaking, radiation has been used as a palliative maneuver. That is, a treatment that can help alleviate symptoms that are caused by metastases. So, for example, a tumor that is bleeding, radiation therapy can potentially alleviate bleeding. Or if the tumor is causing obstruction of an airway, causing difficulty with breathing, radiation therapy can be used to alleviate that obstruction and relieve some of the difficulty with breathing. So that's historically how radiation therapy has been used for patients with metastatic melanoma. I emphasize historically because there is an evolution that's undergoing that's happening right now. And that is, whether or not radiation helps in patients that have limited numbers of metastases. As you know, surgery can be used in people that have metastatic melanoma and limited numbers of metastases. And in some situations can lead to, very good long-term outcomes. And so the application of radiation therapy in a similar manner has also been something that some have been exploring. And this has really been facilitated by advances in the technology. That is, our ability to more precisely deliver high doses of ablative radiation in a safe manner, which has only become possible in recent years based on technological advances.
What kind of modality are you using to target so precisely?
So one thing that's been a big advance is the development of a technique called stereotactic body radiation therapy. And that refers to be able to deliver a very high dose, precisely targeted radiation treatment, which is guided by imaging. That is, before the radiation's being given, really be able to see and make sure that, the metastasis is right where we think it is, and then delivering that high dose of radiation therapy to it. In the last few years, there have been some reports of this in melanoma that look favorable, that make it seem as though metastases can be durably well controlled using these techniques, and that for some people this leads to longer term control of their melanoma.
So, all right, let's close the gap a little bit. So we went from one extreme melanoma in situ stage 0 disease to distant meds, and now we talked about this is mainly for palliative. But what about in the adjuvant settings and then for controlling nodal disease?
Yeah, that's a great question. There have been a few studies, well-done studies, that have looked at using radiation therapy after patients have undergone lymph node dissection for their stage 3 melanoma. Generally, what these studies have shown is that the application of radiation therapy in that situation for selected patients that have high risk nodal disease can help prevent recurrence in the lymph node area following surgery. However, radiation doesn't seem to prevent the development of distant metastasis when used in this manner. So when I talk with patients about this, I always want to make sure they're aware of how radiation therapy for stage 3 melanoma can potentially be helpful, but certainly what its limitations are. And as I'm sure you've discussed in this program, the use of drug therapies for patients with stage 3 melanoma has become more and more common. And so an active question, something we don't really know the answer to is radiation therapy actually still warranted for some of these patients with high risk nodal disease?
That was
And
actually going to be my next questions. Actually, I was going to actually ask you, how does this going to be used in the setting of this immunotherapy, and especially you see some of the immunotherapy moving to the adjuvant setting in stage 2B, stage 2C disease. But sorry for the interruption. Go on.
yeah, no, it's a good question. And, the most obvious situation where we think radiation may be helpful is when we've seen that the adjuvant drug therapy hasn't prevented recurrence. The patients that, have been on adjuvant drug therapy, and then there is another, nodal
Hmm.
recurrence with stage 3 disease. In that situation, we tend to, be using radiation therapy more often these days. Um, but for the patients that are newly diagnosed with stage 3 melanoma, who are having adjuvant drug therapy, it's unclear whether radiation potentially adds some additional benefit. We really need to do better studies to try and answer that question at this point.
So, so what modality are you using? And also, obviously when you radiate the lymph node and you're running the risk of other type of much more side effects, right? Other than just skin erythema, desquamation. Maybe we can talk about that. And what's the modality, how you go about this, and what's the fractionation dose and the side effects.
Sure. So, generally speaking, if we're treating a lymph node basin, we need a more deeply penetrating form of radiation, typically the external beam form of radiation. So in that scenario, we're typically using high energy photons, sometimes high energy electrons, and even sometimes high energy protons. It all depends on the scenario. I would say photons are probably the most commonly used. Um, and the radiation therapy certainly can contribute to side effects. Every time you add another cancer treatment on to the treatment of melanoma, that's going to increase the potential for side effects, and radiation is no different. The dermatitis, as you mentioned, is one possible side effect. It's probably the most common thing we see. And one of the things that's most concerning to patients and to doctors is the development of something called lymphedema,
Yeah.
which there is a risk for following lymph node removal surgery. And radiation, in all likelihood, increases the likelihood of this happening as well. This is most common when lymph node removal surgery has been done in the groin area and radiation therapy follows. It's less common when the lymph node removal surgery is done in the neck area. So there tends to be less in the way of lymphedema that happens. It can still happen, but it's less often there. And this is primarily due to gravity. Gravity helps pull that lymphatic fluid from the head and the neck area back down into the body, whereas just the opposite's happening in the lower extremities, where gravity is pulling those fluids down, making it harder for them to go back up into the body, leading and contributing to this lymphedema problem. So, we factor in the anatomic site when we talk about, radiation therapy following lymph node dissection. We really look carefully at what the factors are for node basin recurrence. There's a few specific ones which, probably have the highest risk. And then, of course, we look at the patient's other treatment history. Have they had other drug therapies in an effort to try and prevent recurrence of their melanoma? And if they have, were those effective? If they weren't, then, we take a longer look at radiation therapy in that situation. But, like all cancer treatments, I think patients need to hear about these options, understand the pros and the cons, and then make a decision, as far as what they think is best that aligns with their goals and priorities for their treatment, for their health.
And then before I make the next point, when you talk about the radiating to the nodal basin in the neck area, and is there any risk in damaging the oral cavity and any dryness of the mouth, or is it just so focused in this region that this kind of side effect is minimal?
No, one thing you can see when treating the neck area or the head area is something called mucositis, which is inflammation of the mucosa or lining of the mouth or the throat. This is very much, similar to what happens on the outside with the skin, the dermatitis. It's inflammation of that epithelial lining of the inside. It's kind of like getting a sunburn on the inside of the mouth, which most people have never had. But just like the skin irritation on the outside, it tends to get better, a few weeks after the radiation's finished. As far as dryness of the mouth, that can happen, certainly as a result of the radiation therapy to that area, as the radiation can affect the salivary glands, on one side of the neck. The good news is that, most of us have functioning salivary glands on both sides. So although in the old days of radiation therapy, when the radiation kind of passed through and through the neck area, these days we have better ways to focus the radiation just to the area where the lymph node metastases are. And we can, prevent some of these long-term dryness type problems that happen after radiation to the neck.
So when patients have mucositis, and they sometimes have trouble eating and swallowing, and what kind of like therapeutic modality do you guys recommend to relieve those kind of side effects, those symptoms?
So, mucositis in general is an inflammatory condition. And just like inflammation of the skin, we'd use a topical steroid. We often use topical rinses inside the mouth. Those can help alleviate some of the inflammation that's there. If the trouble is with swallowing, sometimes we'll use agents that can kind of coat and protect the surface of the epithelium, in the esophagus. Things like Carafate are very helpful for this. And, I think time is probably the thing that helps the most. Again, on the order of a week or two after the radiation finishes, these types of irritative symptoms begin to get better. So it's a lot of it's just, managing pain and helping folks get through that week or two where the mucositis is proving very symptomatic, and, just helping them get through that period of time.
Well, Chris, I know that we're kind of running a little bit low on time, and I think there's one really important point that when you're managing advanced stage patients for melanomas, and sometimes you need the team approach, right? You need a radiation oncologist, you need a medical oncologist, and sitting down and try to figure out, what is the best modality? Should you try immunotherapy first, or should you try radiation, a combination at the same time, and who goes first? All those discussion. That's why I think a team approach is very, very important. So Chris, again, thank you so much for taking the time and chat with us and share all your insight about the research and the clinical aspect of it. And I certainly learned a great deal, and it's been fun. And I think love to invite you back and love to sort of talk a little bit more about various modality, various lotions and creams and sprays and type of thing to make the patient's side effect more tolerable. And I think this is a one thing that something that patients are really, really fearful and anxious about when they're thinking about radiation. So
yeah, no, I agree with all your sentiments. We're constantly trying to do what we can to reduce any side effects of cancer treatment. From my perspective, some of these are technical. They're the machines we use, the way that we plan and deliver the radiation. But, I think a lot of these, also to be aimed at biology and, really kind of trying to target some of those mechanisms that are leading to the side effects that you and I have talked about today.
Well, thanks again, Chris. Thanks again. Thank you
My
for your
pleasure.
time. Bye.
Thanks. Bye, Steve.